this afternoon, everyone. Thank you for joining us for this, our monthly HIV series. This afternoon, we have a dynamic speaker in the person of Dr. Lorna Seybolt. Before we begin, I need to remind everyone to please keep the background noise to a minimum. But again, we thank you for joining us, and we encourage everyone to ask questions at the end of the presentation. Again, Dr. Lorna Seybolt will discuss the pediatric HIV clinical updates. And Dr. Seybolt.
Thank you very much, Tiffany. So I think I'm supposed to stand right here. Hopefully everybody can see me. Just to start with, I think this was advertised as with a focus on opportunistic infections. So when we put this series together, which was a long time ago now, we put the series together for the year in the middle of the previous year, and the guidelines, the pediatric guidelines for opportunistic infections had just been updated. So we were going to focus on that. In the meantime, the antiretroviral guidelines were updated and the perinatal guidelines were updated. So we're going to talk about a little bit more than opportunistic infections. So it's going to be a little bit different than what the title might have implied, but we'll start off with talking about opportunistic infections. But all of the pediatric guidelines sort of got updated. That those came out sort of in rapid succession. The first slide here is just some information for people to have. So the Delta AIDS Education and Training Center on their website has put together sort of a clearinghouse for information on the Affordable Care Act, and it's one place that you can go and get lots and lots of information. The URL is here, but if you just go to the Delta AETC website, you can get a link to all of the information that they've put together and are keeping updated on the Affordable Care Act. So they just asked all of us who speak for Delta to go as we're going out to speak to disseminate this information and let you know that it's available if you are looking for some information. I have no financial disclosures or other disclosures. Like I said, the opportunistic infection guidelines were updated in November of 2013. And then the antiretroviral treatment guidelines were updated in February of 2014, and actually in March of 2014, the perinatal guidelines were updated. We can't talk about everything, so we're not going to talk about the perinatal guidelines. But also on the Delta website, I did a distance-based learning talk recently on the updated perinatal guidelines. So if anyone is interested in that, you can go to the Delta site and hear me talk for another hour on the updated perinatal guidelines. And there, I'll show you the URLs and where you can go to get the guidelines if you want to take a look at them. So for opportunistic infections, what we're going to talk about today is talking about therapy for prevention and treatment of opportunistic infections. So there's a lot of talk about treatment as prevention, treatment as prevention of transmission of infection, treatment as prevention of new infections, but this is really treatment as prevention of opportunistic infections in kids. We're going to talk about diagnosis and management of IRIS, and we're going to talk about immunizations in HEUs or HIV-exposed uninfected infants and HIV-infected children. So that's what we're going to focus on in the opportunistic infection guidelines. Rather than going through, it's about a 300 and some page document, and it goes through each infection. So rather than bore you with, this is this infection and this is what it's about, we're going to try and focus on these things. Under treatment and management, what I'd like to focus on is some of the new information that came out with the update in February. And that some of the important things there are consideration for testing exposed infants after they've completed their prophylaxis, especially if they've been on combination prophylaxis, because there's concern that those tests may not be as accurate in those kids. Changes in recommendation for CD4 monitoring in kids who are actually infected. And that, for people who take care of adults as well, you know, you're seeing some of those changes there as well, that we're probably doing more testing than we need to be doing. And that's probably true in children as well as in adults. So there's been some changes in the guidelines there. And then we'll talk a little bit about when to start and what to start for therapy in kids and the changes that have come through there. So this is what the front page of that OI guideline looks like. You can see November of 2013, it was also published in the Pediatric Infectious Disease Journal. That's when this particular update came out. This is the site where you can get that 370-some page document if you want to take a look at that. It's the aidsinfo.nih.gov. That's the clearinghouse for all of the guidelines, pediatric and adolescent and adult guidelines. If you're not familiar with that, it's a pretty easy site to navigate. You can find all of the guidelines there and all of the updates and any previous ones that you might want to take a look at. And they actually, you can get a PDF of the entire document if you want, or just the tables, or just kind of an update. So depending on how much interest you have in this, you can look at the whole thing or just some pieces of it. So we're going to start with a case to kind of put this a little bit in perspective for you. So this is, I'm not supposed to move around too much. I'll get back here. So this is a patient that I've been seeing for maybe about a year. When he first presented, he was 11 years old, and he was having some difficulty swallowing and had some significant weight loss. So he wasn't just an 11-year-old who wasn't growing normally, he was actually losing weight. So that's pretty abnormal for a boy his age. He got referred to the gastroenterologist, the pediatric gastroenterologist, because of the difficulty swallowing. And they said their anticipated diagnosis was this thing called eosinophilic esophagitis, which is kind of a big thing in gastroenterology, or at least pediatric gastroenterology these days. We're not really going to talk too much about that, but that's a little bit of a hot topic if you've heard about that. Called eosinophilic esophagitis. So that's what they thought they would find when they scoped him. That's kind of what they anticipated. And anyway, he was seen by one of the fellows, and they went and did the scope, and what they found was an esophagus full of candida. So you really, apparently, couldn't really appreciate it very much in his mouth. He didn't really have much in the way of thrush. But when they got down into his esophagus, they said, and they showed me the pictures, it was pretty much full of candida. So they appropriately ordered HIV testing on him, and his HIV test was positive, and then the fellow called me, sort of panicked, and said, what do we do now? And said, bring him in and we'll talk with him and his mom, and we'll have sort of a joint follow-up appointment. So that's what we did. We met actually initially with his mom, and then with him. So these were his initial labs. When GI had seen him, his white count was a little bit low, but it certainly wasn't this low. So his white count was 1.6. He was quite anemic. His platelets were okay. You can see his initial CD4 count was 0. Sometimes we see pretty low CD4 counts, not usually 0. His viral load was 140,000, and his genotype showed no resistance. So that's where he was when we met him in infectious disease when he was 11. So any thoughts? Anybody have any thoughts about this little guy?
Perinatally infected?
Yeah, exactly, Donna. So this was a missed perinatal infection, almost certainly. We had a lot of, and we still have some challenges with him and his mom. His mom hasn't actually told us that she's been diagnosed, but she does tell us now that she has a doctor and she's had some tests and she's on some medicines. But it's not at all clear what happened when he was born, what kind of testing she might have had or might not have had, and really what happened to him in those intervening years. But I just put this up as sort of a, as an opportunistic infection presentation. So here's this young man who presumably was relatively healthy up until the past 6 months or so, at least from the reports that we were getting from the mom. He was, I didn't put this on the slide, but so he was actually started on fluconazole by GI right after he had the scope and was actually doing much better clinically when we saw him. By the time we got him back in for an appointment to go over his testing, he was doing better. His symptoms were improving on fluconazole. We started him on OI prophylaxis while we were waiting for his genotype to come back, and we have since started him on antiretroviral therapy, 3-drug therapy, and his virus came down very quickly, and he's still pretty young, so his CD4 count has come up into close to the normal range also very quickly. So he's at least medically doing very well, though he still doesn't know his diagnosis as far as we know. So getting back to the guideline, that hundreds of pages of document will give you all kinds of information that you want. It gives all of the epidemiology, clinical presentation, everything about the diagnosis for all of the different opportunistic infections. You can get any information you want to know about prevention of a first episode or prevention of exposure, when do you stop primary prophylaxis. All of that information is in the guideline. How to treat them, what happens if treatment doesn't work. So it's full of information. And if you have a child with a particular opportunistic infection, it's actually very helpful. You can go and look up whatever particular infection it is and get a lot of information about how to manage that in one place. So what are the specific pediatric considerations? I know there are a lot of people, at least at this site, who do a lot with pediatrics, but I think maybe a lot of other people are more used to dealing with adults with opportunistic infections. But things we think about in pediatrics, right? So we have sort of two populations in pediatrics. We have perinatally infected kids, and then we have what people refer to as behaviorally infected kids, which is a little bit of an odd term, I think. So kids who are infected outside of the perinatal period, who are not vertically infected, however you want to term that. So they're kind of two separate populations. But if you're thinking about perinatally infected kids, they're a very specific population. And we know that HIV-infected women are more likely to have co-infections with other organisms that they can transmit to their babies. And women with HIV are more likely to transmit other infections. So there's that issue for pediatrics and perinatal infection. And then they're also more likely to transmit horizontally to children. So not just vertically to their babies, but also horizontally within the household. So it becomes an issue not just for HIV-infected babies, but also for exposed and uninfected. So this guideline focuses not just on the HIV-infected, but also the exposed and uninfected infants and children. These slides, I have a bunch of these slides in here. These are put together by the National Resource Center, the AIDS Education Training Center National Resource Center. They have slide decks on a variety of things. This one is for the pediatric OI guidelines, but again, this is like 277 slides. So I just pulled some of them out. If you want access to these slides, these are at the National Resource Center site. I put the URL at the end. You can go to their site and look at all of their training resources. Those are all available if you have, if you want to look at them, for your own education, or pull any of those slides for any kind of talks or educational activities that you're doing. Those are all available. So this is just their information about the sort of pediatric specific things that we just talked about. So for things like CMV and Hep C, we know that when you have one, you're more likely to transmit the other. So those are things to think about. And then the horizontal transmission that we talked about in the other slide. Okay. And then how do little babies keep from getting sick, right? They rely on maternal antibodies. And that's, that transmission of those antibodies is less in women with HIV. So those babies have less protection, whether they're infected or not. They're not as well protected. So again, that's a consideration for both infected kids and kids who are just exposed to HIV but are uninfected. And then you have the issue of how do you diagnose an opportunistic infection in campus. So they can't describe their symptoms, right? So some people say that pediatrics is like veterinary medicine, which I don't necessarily agree with, but people say that because kids, I know, Dia's looking at me like I'm crazy, because kids can't necessarily tell you what's going on, especially very young kids. So they can't tell you, so you're trying to do a review of systems, right? And those are you need somebody who can talk to you about those. So that's a little bit of a challenge. But we get around that in pediatrics. Pediatricians know how to get around that. And then there's this issue of maternal antibody. So we want these babies to have as much maternal antibody as possible because it's protecting kids from getting sick, especially when they're very young. But then it makes it hard to diagnose some things that we generally use antibody testing for. Because maternal antibodies in there, and we don't have any sort of technology that can tell us that this antibody is maternal versus baby. Now there are some things like IgM antibody that doesn't cross the placenta. So IgM antibody in a baby is baby antibody. So there are some caveats to that. Okay, and it's hard to get sputum, right? So if you're thinking about something like PCP or TB, how do you get sputum from, you're shaking your head. Yeah, it's hard to get sputum from not just a baby, but a young child, right? So we do things like gastric aspirates, right? So that's basically putting a feeding tube into a baby or a young child's stomach, usually first thing in the morning, because what they do is, what you like people to do is cough things out. What they do is they cough and swallow. So you can suck out the contents of their stomach first thing in the morning and test that for certain things. So gastric aspirates certainly can be used. But so those are just some things to think about when you're thinking about how do we deal with this in the younger age population. This slide I think is a little bit confusing, but it does give you some information about what we're talking about in terms of opportunistic infections. And it's talking about the pre-heart era and common OIs, and these are more common, so greater than 1 event per 100 child years and less than 1 event per 100 child years. And you can see bacterial infections like pneumonia, zoster, PCP, and then CMV and toxo are kind of down here in the common but less common. So those are the different OIs. And again, this is pre-heart era, although when we come up to definitions, they don't call it heart anymore, they call it combination antiretroviral therapy. So they've changed that a little bit as well. So you can see when you're thinking about, okay, what we talked about at the beginning, like treatment as prevention of opportunistic infections. So this table shows the rates of several different infections, pre-heart versus post-heart. And you can see what's happened to those rates with the introduction of therapy. So we're seeing less and less opportunistic infections in kids as kids are getting on effective therapy. You can see the rates of everything. Some of the rates were not very high to begin with, and those rates have dropped as well. So some other differences between kids and adults. So in adults, you often think of opportunistic infections, right, as reactivation. That's often what you think of those. Yeah, people are nodding. That those are reactivation. And in kids, they're often primary infections. So that's somewhat different. Babies' immune systems are immature. You get different disease manifestations, so you're not always looking for sort of the classic picture. And here, where they're talking about tuberculosis, right? So kids, especially kids under the age of about 5, tend to get disseminated TB rather than pulmonary TB. So that's something to think about. And then you might not see the classic features that we think about or get taught about in things like nursing school and medical school, sort of the classic disease processes. So what's new in this guideline, right? You don't want to read 377 pages of guideline. What's new? What do you need to know about? Again, prevention is treatment, especially there are a lot of them that don't have specific treatment. So for those getting patients, like the young man that I presented initially, getting his esophageal candidiasis treated, right? So there's a treatment for that. So getting him on fluconazole is going to get him feeling better, but getting him on antiretroviral treatment and getting his CD4 count up is also going to get him feeling better. There's more information on iris, which we're going to talk about in a few minutes. And then there's some more emphasis on drug interactions, right, within the guideline. And we're not going to focus on that today, but that is in there if you're looking for that kind of detailed information. There are also new immunization recommendations, and there's information in there, again, for the HIV-exposed uninfected babies and infected children. And they've changed some of the sections. And I don't know the specifics behind why. So this is all a committee of experts that puts together these guidelines. So it's not necessarily clear how things end up in the guideline and then get taken out. You can see some things were taken out, Aspergillus, Bartonella, a couple of human herpes viruses were taken out, and then they added in sections on influenza and Giardia and Isospora. And they updated the recommendations on when you can stop prophylaxis. So that's all what's new. So generally when a new guideline comes out, this is sort of handy, there'll be a summary page or 2 or 3 that tells you what's new. So if you're fairly familiar with the old guideline, you can kind of see what they've been up to. So this is the new terminology I was talking about. Are people familiar with this? You got to change the terminology every few years just because it makes old people like us feel more old, because then there's new terminology. So we've been calling it HAART forever, right? Highly active antiretroviral therapy. Now they want us to call it combination antiretroviral therapy. There are people here at this site rolling their eyes. I can see this. And that's multiple drugs. And then ART is a general term. I find that, I don't know, it's more or less confusing, but in any event, this is one of the changes. There's also a change in the perinatal guidelines. To talk about that, we used to call it prevention of mother-to-child transmission. Now they call it prevention of perinatal transmission. So there's been, that's coming up on another slide. There's been terminology changes. We put in a few slides on iris, because that was a little bit more of a focus in this guideline. So that was one thing we worried about in the patient that I presented, right? So his CD4 count was 0. So one thing you worry about in patients such as that is, as you're treating them, which is what you want to do, is are they going to get immune reconstitution issues? He did not, fortunately, but we do see it sometimes in children as well as in adults. And there are 2 varieties of that you can think about. Paradoxical, which worsening of symptoms when you have an existing or an active infection, and then unmasking. So if you have a latent infection, then that gets unmasked. So it's just, that's a little bit esoteric, a little bit of an esoteric point, I think. But if you read those two different terms, that's what they're getting at. And it's an inflammatory etiology. It's really not, it's not the infection, it's the body's inflammatory response. So you had no immune response. So you weren't really reacting to these infections, and then you start to, the immune system starts to come back, and then you have that inflammatory response. And it should be temporary worsening of symptoms after you start therapy. And we'll talk a little bit more specifically about treatment, but it's essentially either nonsteroidal anti-inflammatories or steroids. This is a clinical definition, right? So if you start therapy and the viral load goes down, right? So that's sort of a precondition. And you get this worsening illness, and it's not explained by something else. So it's not side effects from the medicine. It's not a new infection. So that this is sort of the idea behind immune reconstitution inflammatory syndrome. These are the most common ones we see in children. So mycobacterial infections, we think about TB, but in adults, in kids, other mycobacteria, zoster, herpes simplex, sometimes cryptococcus, and BCG reactions, which we don't really think about in this country because we don't give the BCG vaccine here. But in other countries where BCG vaccine is given at birth, sometimes again at a year, you can get a very exaggerated response to, that's a live vaccine, that's a TB vaccine, and it's a live vaccine, and you can get a very exaggerated response to that in someone whose immune system is recovering. So treatment, so for very mild symptoms, you can just watch them, monitor them closely, maybe see them more frequently than you would have otherwise if they're, to see which way they're going to go, where that balance is going to be. Nonsteroidals, like we said, for sort of moderate symptoms, and then steroids for more severe. What's the dose and what's the duration? Nobody knows exactly. Like we were talking about, these should be temporary, but they can last months, and they can cause pretty significant symptoms. Kids can be pretty miserable with iris. If people here have had experience with patients who've had kids who've had this, it can be very sick with these symptoms. I'm not going to ask you what the 16 are, but probably as a group we could come up with all 16 things we vaccinate against, if you think about it. They update these schedules at usually January 1st and July 1st. They'll come out with an update for adults and for kids. All right, there's a routine schedule, there's a catch-up schedule, there's information for HIV-infected kids and adults. And that's where you'll find the information. If you happen to be looking for information about immunizations, you will find that information in the OI guidelines for both children and adults and adolescents. The immunization information is in that guideline. So, and we get calls in infectious disease about immunizations for immunocompromised. And for the most part, as long as it's an inactivated vaccine, it's fine. It might not work very well. So that's really the issue, suboptimal effectiveness. So oftentimes the call is about, is this vaccine safe for a patient? And if there's a problem with the immune system and it's an inactivated vaccine, then the vaccine is safe. The question is it going to be effective? Right? Then the issue is with live vaccines. And the common live vaccines that we give, especially to kids, measles, mumps, rubella, right? Varicella. We don't have oral polio here anymore, but that's a live vaccine. We use the inactivated injectable form. Rotavirus is a live vaccine. The oral typhoid vaccine is live. yellow fever. So there are other ones that we don't really think about because we don't use them very often. But so those are the ones that we worry about. If you're less than 5 years old and your CD4 count is more than 15%, it's okay. And if you're greater than 5, you can use the absolute CD4 counts. And we think, so young children have much higher white blood cell counts. They have higher CD4 counts in general, so we talk about percentages rather than absolute numbers. Less than 15% is highly immunosuppressed. 15 to 25 is sort of moderate, and over 25 is okay. So that's where we are with the live vaccines. So those are the ones you would need to be careful with in someone who is immunocompromised. Okay, this question comes up, right? Rotavirus vaccine. So we had a rotavirus vaccine, and then there were these issues with intussusception, and it went away, and then we didn't have to worry about it. But we have a lot of rotavirus disease in this country, and especially in other parts of the world. And now we have rotavirus vaccine is back. It's an oral live vaccine, and it's given, you can give it as early as 6 weeks, and you have these HIV-exposed babies who haven't ruled out yet. So what do you do with those kids? So we get those questions sometimes. What do we do about rotavirus vaccine? Because there's sort of a finite time period when you can give the rotavirus vaccine. So not a lot of data, but as long as even an infected baby, that baby that you know is infected, has a reasonable immune system, and the rotavirus vaccine is thought to be safe, and you should go ahead and give it, that the benefit would outweigh the risk. So that sometimes comes up as a question. Rotavirus vaccine. Measles. And you know we're seeing more measles in this country. You maybe have heard reports about measles outbreaks and unimmunized or under-immunized populations. So we are seeing more measles. And what's been found in studies is that kids who got measles vaccine before they were on effective therapy do not have good antibody levels. So re-immunizing those kids is generally what's recommended. And this is a little bit historical because for the most part, kids now who are perinatally infected and getting diagnosed are going on more effective therapy. So by the time they're ready for their measles vaccine, they should be on effective therapy. But that's just something to keep in mind if you have an older child or adolescent. Okay, this is the other guideline I wanted to talk about. This was updated in February. This is the Pediatric antiretroviral guideline. Again, you can go to the same website and get this 200 or 300 page guideline. We're going to talk about this case, and then we'll talk about what's new in this guideline. So this is a baby that I met when she was about 2 months old. She came into the hospital because she had a cough and a fever. Her mother said she was kind of choking when she was coughing, so she was quite concerned about the kind of cough she was having. She had a little bit of change in her stools. You might look at that and say yellow loose stools is kind of normal for a 2-month-old, but this was different for her. She had a brother with a URI. So initially, her mom thought, oh, she caught her brother's viral infection. She was born at term at a local hospital, no complications. By report, she had most of her prenatal care in another state, and it was unremarkable. We never got those records. And also at this point, Mom said she had a rapid HIV test at the local hospital, and it was negative. She was able to show us that eventually. She wouldn't let us keep it or make a copy of it, but she did show it to us, and it was negative. She lived with her mom and her dad and 4 of her siblings. So she looked pretty good initially. She had some thrush, but again, this is a 2-month-old baby. It wasn't significant thrush. It was a little bit of baby thrush. She had a little bit of diaper rash and some coarse breath sounds, but she was otherwise looked okay. Her initial labs were a little bit concerning. So her white count was lowish, but not below the lower limit of normal for that lab. Her hemoglobin was okay, right? So babies at 2 months are kind of at their nadir for hemoglobin. So you might say, 9.4 is kind of low, but that for a baby her age, not bad. Platelets were low for no particular reason that we knew of, why her platelets would be low. And her transaminases were a little high. And she got admitted, had some more fever, started to look a little bit more yucky. And 2 days later, all her labs were repeated, and she was pancytopenic. I saw her. We sent her urine for CMV. We tested her for syphilis, and we tested her for HIV, which came back a few days later positive. She got started on Bactrim for PCP prophylaxis, so that was sort of the first half of the talk, or OI prophylaxis. She was started immediately on Bactrim. Her viral load came back at greater than 20 million, which is, for a baby, is not necessarily unheard of. Her CD4 count was okay, and she got started on zidovudine, lamivudine, and lopinavir, ritonavir. She has, her viral load actually came down fairly quickly on this regimen, which is, which tends to get the viral load down pretty quickly. And she has since switched her regimen, which we're actually going to talk about because there's something that came up in the guidelines, which is a little bit problematic for her. But she medically has done fairly well. She's had some other issues, but medically she's done fairly well. So this is what's new in the guideline, right? So we had this HART change to C, combination antiretroviral therapy. So this, what we've all been used to saying, MTCT and PMTCT, has been changed to perinatal transmission and prevention of perinatal transmission. So we have new terminology for mother-to-child transmission, because the committee decided to change that terminology. I don't know if you've heard that. People are hearing that. And then this is a new recommendation. So normally we test babies at, sometimes at birth, and then at 2 weeks, at 4 to 8 weeks. We usually try to do it at 4 to 5 or 4 to 6 weeks. And again at 4 to 6 months. So the recommendation here is, especially for babies who are on combination medications, that may be problematic for testing those babies. So if you have a mom who was not very well controlled, or was diagnosed in labor or late in pregnancy, and you're putting the baby on more than one medication, that you might want to consider repeating that testing after you get the baby off prophylaxis. So oftentimes we're doing that second test while the baby's still on prophylaxis. And then we're calling those babies who are negative at 2 weeks and negative at 4 to 6 weeks as presumptively negative. So this was new in the guideline. And they talk mostly about for kids who are on combination therapy. And it may not be as much of an issue for babies who are just on AZT.
You mean those babies who may have had to have AZT and the therapy?
Or if they're on AZT and 3TC or something else. Or for whatever reason. The baby. And then monitoring, and people who take care of adults, I'm sure have seen some of this as well, that we're probably overdoing it with the labs. We don't need to be checking labs as frequently. So if you have a patient who's adherent to, these are a lot of ifs, right? For people who are just laughing. Yes. If they're adherent to therapy, if their CD4 count is well above, either 200 or 15%, their virus is suppressed and has been suppressed, and they've been stable for a couple of years, a few years, then you probably don't need to check their CD4 count as often as we do every 3 to 4 months. So if you think about how many kids you have in there, you might think about that. Now, there was a comment made yesterday at a planning council subcommittee meeting about not seeing patients as frequently. Now, this is not necessarily to suggest that you're only going to see these patients every 6 to 12 months, just that you don't necessarily need to check their labs as frequently, but you still want to be seeing them and checking in with them and making sure that all of these other things are going on, like they're still adherent to therapy and all of those things. Okay, so there's a section in the new guideline, of course, about the Mississippi baby. Everybody's heard about the Mississippi baby. We're in Louisiana, so lots of people here, I'm sure, even other places have heard about the Mississippi baby. So what do we do with that information? Nobody quite knows for sure. So we don't really have any good data on these medications in very young neonates. So we know about AZT in very young neonates and, a few doses of nevirapine, but we don't really know we know for this baby that it worked, and it probably wasn't particularly toxic as far as we know. No treatment interruption, okay? So this baby had a treatment interruption, but that wasn't a scheduled treatment interruption. That was mom sort of disappeared with the baby. So treatment interruption is not recommended at this point. And there isn't really a good recommendation for what to do if you have a mom who shows up delivering a baby and you discover, or you are highly suspicious that she has HIV and a high viral load and a low CD4 count. So just because we don't have good pharmacokinetic data on these medications, we know that some of them, like, we use a lot of lopinavir or tonavir in young babies, but we know that in very young babies that can be toxic. So we're still not quite sure what to do. So committee hasn't come out with a recommendation for that. And then anybody with a viral load over 100,000. That's in the new guideline to start. This is a table from the guideline, and there's nothing. I'm sure it's hard for you to read, but there's nothing in here that would surprise you, right? If you have a high viral load, treat. If you're symptomatic, treat. If you're less than 12 months of age, treat. And the reason for that is viral load and CD4 count are not very predictive in those kids. So as children are older, you get more information from those numbers. In younger kids, you can get very sick very quickly. So anybody less than 12 months should get treated. And then they break it down into 1 to 3, 3 to 5, and greater than 5. So AIDS or significant symptoms, treat. Then if you're kind of doing okay, you can consider not treating, although most people are, for the most part, in the considering treatment, recommending treatment. So there's nothing particularly unusual in this table in terms of when to treat. But this was a new, anything in yellow, so if you pull it up online, the guideline, and you're just flipping through it, anything highlighted in yellow, that's new for the update. Okay, what to start and what not to start. We'll talk more about what to start. Again, this is not anything particularly new, although they do give you some information about, there's efavirenz over here, and this is darunavir. So there are some recommendations for some newer medications like darunavir for use in children. And again, you can look this up. This is obviously not something you're going to take away from this talk knowing, like, what am I going to start a kid on? But just know that you can get this information, and they do take a look at the newer medicines. And the other information that you can get in this guideline, right, so we do in pediatrics give kids medications that are not specifically FDA approved for kids under 18 or whatever age they happen to be. But this guideline will give you some guidance on how to use those medications that the FDA hasn't specifically approved for kids. This is a whole new table. What's the NRTI backbone? And then alternative NRTI backbones. You can see there's a lot of AZT or ZDV or zidovudine in here. when I talk to adults, people who take care mostly of adults, and you start talking about AZT, and they get sort of like, nobody's on AZT, and nobody wants to be on AZT, but we have a lot of kids on AZT because there's a lot of experience with it, and it works. And it comes in a liquid formulation that's relatively palatable and a reasonable volume. And like I said, we have a lot of experience with it, so there are more kids on it than adults. But if you talk to adult providers about it, they are often surprised by how often AZT turns up in a recommended regimen. Okay, so some other things that are new are consideration for changing a regimen that might be working to make things more simple or easier to adhere to for kids and their families. How to look at treatment failure and treatment interruption. Therapeutic drug monitoring. So we don't do very much of this except in studies. So obviously it's not routine. Sometimes for drugs that haven't been used as much in kids or just coming out with recommendations for kids, you can use it. Depending on what kind of interactions you're looking at, if the response isn't good, you can usually find another reason for the response not being good. We have a child recently who was viral load all of a sudden shot up to 90,000, and we spent a lot of time trying to figure out if that had to do with his growth hormone that he just started or what was going on. But if you spend enough time with the family, you find out that, well, grandma finds out that his medicines are under his bed. So there are probably other reasons that don't require therapeutic drug monitoring that you need to explore before you go through, because this is a very intensive thing to do, oftentimes. Okay, this I think is a big deal. And the reason I think this is a big deal is because we use a lot of Kaletra, liquid Kaletra in little babies because it comes as a liquid, very effective. That baby that I presented, we started on Kaletra, it gets the viral load down very quickly, so you get all that virus away from that baby's developing brain. But it's nasty. Anybody been around liquid Kaletra? You get near it, you get it on you, you can't get it off. It's the ritonavir component, but it's a nasty liquid medicine. Kids don't like it. They figure out which one it is. I had a patient who, when he was very young, knew which one of the 3 liquids was the Kaletra and would dump it out. And just that one. Not the other 2, but just that one. So when they came out with a recommendation or an approval that you could use efavirenz down to little babies, you could open up the capsule, sprinkle it on food or put it in formula, great. Like a revolution. Because we don't have a lot of options for very young babies. We have nevirapine, which doesn't have, if you mess up nevirapine dosing, you can end up with resistance, right? The barrier to resistance is very low. So that's a problem. So I thought, this is great. So now I have these 2 little ones on efavirenz, and then this comes out, that there's some issue, especially in very young children, with efavirenz. And that there are fast metabolizers and slow metabolizers. So there are probably kids out there on efavirenz, little ones, who are either getting too much or not enough. And so we probably shouldn't be using it in kids under 3 years. But if we are, there's this polymorphism you can look for, according to the committee and NIH. But if you try and find this test for your patient, it's not so easy. So I think this is, for me anyway, like I had switched 2 very young children, definitely under 3. So hopefully this is maybe not as much of an issue. So raltegravir comes as chews. You can use that down to age 2, and now it comes as a liquid. Raltegravir just came out as a liquid, and you can use that now in little babies. So we are getting more and more options for kids. I guess the message is more and more options. But it wasn't too long in between the approval for very young babies and the, maybe you should be careful in the young kids. So we're getting more options, but we just need to be thoughtful about what we're doing. Okay, diagnostic testing, we sort of alluded to this. We're using virologic assays, right, because we talked earlier about maternal antibodies being a problem for diagnosing opportunistic infections. DNA PCRs or RNA PCRs. DNA PCRs are getting harder to find, but they are preferred, especially in the young children. 2 to 3 weeks, 1 to 2 months, and 4 to 6 months are generally when we test. A lot of hospitals do tests at birth as well. Infants at high risk of HIV. So if you think about perinatal transmission, you can think about intrauterine, intrapartum, and then breastfeeding. And most of it happens intrapartum. So that birth test is probably not going to pick up the intrapartum, but if you were to have an intrauterine infection, you might pick that up at birth. So that's kind of the thinking process there. If you happen to get a positive, we do sometimes have false positive DNA PCRs, so you want to repeat that. And then we talked about that as the new thing in the guidelines. And again, these are the slides from the National Resource Center. They have a slide deck on this too. It's 200 or so slides if you want to go through and take a look at any of those. So we talk about definitive exclusion. So we talk about presumptively negative babies who are negative at 2 to 3 weeks and 4 to 6 or 4 to 8 weeks. If you want to definitively exclude a baby, 2 or more negative tests, and one of them has to be at more than a month and one at more than 4 months, or if you have 2 antibody tests. So sometimes we get kids that turn up later in life that we didn't know about or that missed all of their earlier appointments, and so you can do antibody testing. And certainly older kids once maternal antibody is gone, although sometimes maternal antibody lingers a little bit longer than that, and you get indeterminate tests. This is just some information and then newer information about, so if you have a mom who gets diagnosed and she is breastfeeding, what do you do about that? So the first thing is test. Well, first thing is stop breastfeeding, test, and then follow-up testing. So about 10 to 15% transmission with breastfeeding, depending on how long that's gone on. And then we talked about this, CD4 counts, using percentages in the younger kids. So that baby that I talked about who had a viral load of greater than 20 million at 2 months, she was probably at the peak of her viral load. We don't know how high it was, right? It was greater than the upper limit of the test. We don't have any way other than diluting the specimen, which most commercial labs are not going to do for you, of knowing exactly what it was, but it did come down fairly quickly, but she was probably, she was right here. So, and like I said, the predictive value is not great in that age group. We generally, I think most people have a test that goes down to 20 copies at this point. And 5-fold change or a 3-fold change in older kids. So people get really focused on what's going on with their viral load and changes, but just be aware of what may be clinically significant, and verifying that with more than one test, like we did with this little guy who ended up with his medications under the bed. We sort of got one back, and I thought, well, that can't be, because I just saw him, and they said they watch him take his medicines, and he's doing great, and he was actually doing much better at that visit. He was much more interactive. Everything was going really well. And I thought, that must be a mistake, but it was not. This is nothing new or different from anything else that we've been doing or that you might do on the adult side. What you're doing at entry and follow-up for kids not on therapy, watching their CD4 count to make sure they don't need to get on therapy. We usually do it at least a phone call after they start treatment. Sometimes we'll see them. Looking at labs at a couple weeks, both for toxicity and for response to therapy. And then again, less frequent monitoring that we talked about before if you have somebody who kind of fits into that nice picture. This is important, like we talked about with some of the liquid formulations that we have. This is something to think about if you're talking about a very young child and you're talking about therapy for the rest of their lives, and what you're thinking about putting them on and what they may be developing resistance to if they're not doing so well with adherence. And then when you're thinking about changing, obviously you have both the child and whoever is helping them with their medicine, depending on how old they are, to consider. These are the same goals really for everyone. You don't need to go over these specifically. You're trying to suppress the virus, minimize toxicity, reduce transmission. So we already talked about this, that if they're less than 12 months of age, they're going on treatment right away, and that they don't predict, their lab markers don't predict progression. And we talked about that if they're symptomatic, of course, they're going on treatment. This is helpful information in the appendix. And like I said, if there's information in there that's different from what the FDA says, you can get that information there, which is helpful. Because a lot of times when you look up like in a drug book or a drug reference, it will say things like, not approved for under 18, or something like that. But here you can get information, more specific information for children. I'm not going to talk really too much about adolescents. They put some of these considerations for adolescents in the pediatric guideline that's specific. Recommendations. There's an adult and adolescent guideline, but what you really want to think about is where is the child sort of in their Tanner staging and puberty, right? Because someone who is almost fully through puberty, you're going to be looking at the adult guidelines, adult dosing, that kind of thing. Someone who's in early adolescence are going to be on the pediatric side of things. So that's just something to keep in mind in those early adolescent years. Okay, so we talked about that. Is it palatable? That's an issue. Pill swallowing difficulties. We had a psychologist who's very good at teaching kids how to swallow pills with things like fruit roll-ups and stuff. So that can be very helpful, especially kids who are highly motivated to get off liquids. That can be really helpful. Outside the home. This is a problem, and this is sometimes a problem inside the home, depending on who knows what the diagnosis is. We have people who peel labels off bottles and that sort of thing, because not everybody, even within the house, knows what the diagnosis is. And then, when do you let the child give themselves their medicines without monitoring? That's a very obviously individual question and very important, and sometimes it's a moving target. So sometimes early in adolescence, kids do okay, and they will take their medicines, and then they get to a little bit later in adolescence, and then they decide they're done, and they're not going to do it, and they actually need more supervision, and they sort of go back and forth. So it just depends. School hours. So we have families who say, do I have to tell the school that my child has HIV? No. And most medicines now are such that they're once a day or twice a day, so there often isn't a need for a school time dose, so that's actually very helpful. So this, and then there are other, obviously, multiple other social issues that may be going on. We have a mom who moves a lot. But the first thing she does when she moves is call the pharmacy, because she gets her meds shipped to her. and the pharmacy knows she's moved before we know she's moved, which is great. So she has a lot of trouble with literacy, but she gets her medicines, and her toddler gets his medicines, and that pharmacy knows before we know that they've moved. So
they come?
they do. They do. So she's on it. These are just some little guides for what to do for treatment failure and how to go about assessing that. Hopefully you don't have to get to that point, but if you do, certain things that you're already aware of, I'm sure, like pharmacy records. When you call the pharmacy and say, when was the last time that was filled? And they say 4 months ago. That's a good clue. Doing recalls, that kind of thing. And then, is there some other issue that they're taking it and it's not working? So other things to think about when you're having a treatment failure. And I am almost done. Resistance testing if you need to. We're not going to go over resistance testing now, but resistance testing is actually getting better. We used to say you need 1,000 copies to get a genotype. Now, sometimes in the 500 to 600 range, you can get a genotype. Just thinking about postnatal infection a little bit. You know, we talked a lot about perinatal infection for pediatrics, but there are other ways for kids to get infected that are not necessarily vertical transmission that we might need to think about in an older child. Pre-masticated food, that is a big deal in the perinatal guideline now. Talking to moms and infected caregivers about not pre-masticating food. So that's a big topic, again, in the perinatal guideline that was just updated in March. These are the URLs for the different things that I was telling you about. So AIDSinfo.nih.gov, that will give you all of the guidelines. And then these are the two different guidelines that we talked about. The National Resource Center, the AETC National Resource Center, has all of the slide information, all of the slides, and other training materials that you can use. And I put this on here. This is the Florida Caribbean AETC, and one thing they have is they have basically medication trifolds that you can either print out yourself or order, and they have one for pediatrics and one for adolescents and adults, and they update them regularly, and they're really nice. So they will give you like a snapshot. Like they'll say, these are the side effects for the class, and then they'll give you, for instance, Avacavir, and they have little symbols. So with food, without food, hepatic, you need to adjust for hepatic or renal issues. And then it gives how it comes. So what tablet size is, does it come as a liquid, what's the strength, what's the dosing. They give, on the pediatric one, it gives all the pediatric dosing, then it gives sort of the maximal dose for if you're an adult or adolescent. And it's that's a very handy resource. It also gives weight ranges, so you're not, every time a child comes in, we're recalculating their doses. This gives weight ranges for a variety of medications as well. So it's a very nice place to go to get all of that information in a very condensed form. And that's my contact information if anybody wants to email or call with any questions. And that's Cammie. You're welcome. Any questions? Anybody have any questions?
When you're considering the initializing medication for the babies, what kind of factors do you have to consider when thinking about down the road when they become adolescent, young adult, about what the options might be for them to be available for them or what would be effective for them?
So that's a good question. So the question was about if, when you're starting a baby on medicine, what do you think about in terms of long term? So that's something that I think about things like nevirapine. So that's a medication that there's a lot of experience in babies with that medication, but it has a very low barrier to resistance, and then you can end up with resistance to other NNRTIs. So it's more palatable than lopinavir and ritonavir as a liquid. So I sort of struggle sometimes with families who are not doing very well with lopinavir because they can't get the baby to take it because it tastes nasty, but they're not doing very well with adherence. So then do you really want to switch them to a medication that if they're not adherent, they're going to end up with some class resistance? Although with the newer NNRTIs, it's not quite as, they will still have some options. So those are the kind of things that you think about. Now, hopefully if you have someone who's adherent and doing well and keeps their virus suppressed, then by the time they get to being teenagers and they get to that point where they decide they're not taking medicines anymore, hopefully they don't have resistance already, but a lot of perinatally infected kids do, although now that we have better medications from the beginning, I think some of the older adolescents and young adults now who were perinatally infected sort of started out at a time when we didn't have a lot of the options that we have now, and so we're on medications that weren't as good, and maybe we're on and off, and so have more resistance. But it's sort of, you want to think about the future, but you want to get them suppressed now. So you do want to think about both, because you don't want to end up later without options, and you don't want to end up hoping that some new class comes along that they won't be resistant to because they haven't seen it before. Okay?
Okay.
Thank you.
Thank you very much, Dr. Seybolt. We really appreciate that. Thank you all for joining us this afternoon. We hope to see you here next month when the topic will be the effects of alcohol on HIV infection. Again, we look forward to seeing you, and thanks for joining us.